First of all, thank you. Thank Respiratory Associates for having me here today and giving me the opportunity to give this 1 hour lecture presentation. You can see here the topic of this presentation is occlusion pressure. Are you listening to your mechanically ventilated patients? Now, that might strike you as odd, just as a title, because we typically, and what I see throughout my educational process, I've been served the last 10 years as an educator, 20 years overall in the field. But over the last 10 years, I've had the opportunity to work with lots of students. And we give them an assignment where they have to fill out a SOAP sheet or they have to do a SOAP assessment. You're probably familiar with that. The first part of that SOAP assessment is S. It stands for subjective, as we know, right? And so typically, what happens is we see where they go into a room and they talk to a patient, and in that subjective section, they are to ask the patient to rate their level of shortness of breath. And so you'd see things like patients said they were short of breath, or the patient denied any shortness of breath, or whatever it might be. But they're interacting with the patient and they're talking to them and they're listening to their feedback. Well, then we transition into the ICU world. And now they're taking care of mechanically ventilated patients. And this subjective area turns into more of where we see a lot of times where it says patient mechanically ventilated and sedated, unable to communicate with the patient to assess their shortness of breath. And while that may be true on some levels, since I've been diving into and learning more about occlusion pressure, I've come to realize that there is a way for us to communicate with even our most sedated patients in the ICU on mechanical ventilation. And the whole purpose of this lecture today is to show you how and to hopefully illustrate to you the value of airway occlusion pressure. So let's jump into it. You know, we have some objectives, of course. We're going to ultimately define what airway occlusion pressure is. By the end of this, I hope you understand its value to you as a clinician and how to apply it during the weaning process, and also how to apply it during all phases of the mechanical ventilation process. So those are some things we're going to be touching on. First of all, I just want to say glad everybody's here today. Doing something a little different today, so I'm really going to look forward to a lot of feedback from you at the end of this, because one of the things you're going to notice during this presentation is that there are going to be no bullet points and very little words. So it's just going to be a lot of images to help drive home this idea of what I'm talking about. Now, before we jump into actually what is occlusion pressure and how we monitor it during mechanical ventilation, I think it's important to first recognize where this is all going to start at. And it's all going to start with this concept of dyspnea. So we know patients or people or humans or anybody in general can experience times of distress, times of shortness of breath. We know that word is dyspnea. Now, while scientists don't really understand the true pathophysiological mechanisms that are happening to create this sensation, what we do know is that it can be caused by a wide array of different elements. It can be pain, fever, anxiety, fear, the discomfort, hypoxemia, and hypercarbia, two of the most highly related to us as cardiopulmonary experts. We know that all of those things in different ways, even exercise. If I was to go run downstairs, I would be short of breath. And I would experience this element of dyspnea that would be hard to say exactly what's going on, but I know what it would be related to. So for us, we know that we have this mechanism that is present, but it doesn't really tell us what it is. Now, here's what we know. When we talk about the mechanics of ventilation and we tie it into dyspnea, what we know is that the central drive to breathe, now I'm going to refer to this throughout this presentation as the neural drive to breathe, okay? But the central drive to breathe originates from the central chemoreceptors located within the medulla oblongata. And I don't even know if anybody can ever say that word without thinking of Waterboy, but that's where my mind goes immediately. But we know here essentially in this region here in the medulla oblongata, we have the central chemoreceptors, and they communicate with the diaphragm. So you have this connection between central chemoreceptors, neural drive to breathe, and you have the diaphragm. And this pathway, as we know, is the phrenic nerve. And what happens is in normal respiration, this is happening for all of us right now, the central chemoreceptors send an impulse down the phrenic nerve to the diaphragms, and the diaphragm contracts. This is normal, basic, everybody understands this. What happens during times of distress, during times of dyspnea, is that this impulse signal gets larger. And what that equates to is a bigger, stronger contraction of the diaphragms. And this is what happens. So essentially, the more distressed the neural drive to breathe becomes, the greater the impulse signal sent to the diaphragm becomes. And then secondary, the diaphragm contracts harder. Now, the key thing here is that it's not readily available and ideal to be able to measure the strength of this impulse or this neural signal. So how do you assess the actual measure, the actual impulse? That's quite complicated to do, if possible at all. What we do know, though, is that if the strength of the diaphragmatic contraction is proportional to the strength of the signal, then we can simply measure how strong the diaphragm is contracting. And that's where this is going to come into the occlusion pressure. Now, this concept originated back in the mid 70s. Is some of the earliest recordings I can find of it. If you do any type of searching on airway occlusion pressure, you will most definitely find an article from, I want to say, 1978. The research started around 1975, and it was published. And that kind of blows my mind, because it says that we've been studying this, or at least known about this, for about 50 years now. Yet it seems to, at least for me and my experience, has been a forgotten topic or a forgotten tool that we can use. Because what we found was, like, if we can measure this diaphragmatic excursion, then we know what our impulse signal is, which is a direct reflection of neural sensation or distress. Now, here's what it looks like when you put it into a pressure waveform type setting. We know that we're running along right here at PEEP, and then the diaphragm is going to drop. It's going to initiate a breath. And so you see this drop in the diaphragm, and then it comes back up on exhalation. We know this is the way it works. But when you're talking about airway occlusion pressure, it's first of all important to understand, what measurement is that? What are we looking at when we talk about airway occlusion pressure? And the answer to that is we are looking at the first 100 milliseconds. Let's put that into context just for fun. Last night I was preparing, and I pulled up on Google a millisecond timer. And I said, let's just see how long 100 milliseconds is. And you can't measure it. It's harder than trying to stop the gas pump right on $50. It's impossible. It's to wrap your brain around a first 100 milliseconds of an inspiratory phase is incredibly fast. That's why you will also see occlusion pressure expressed as the P100, and you will hear me refer to it as the P100 throughout this presentation. Now, what this is saying is I'm referring to the first 100 milliseconds of the inspiratory phase. Now, you can see it expressed another way, as it's listed right here, where it's also reflected as the P.1, because we know 100 milliseconds is a tenth of a second. So you can see where it may also be illustrated like this. When you're seeing this on different ventilators or different research, you're looking for P.1, P100, or airway occlusion pressure. All of those are referring to the same thing. Now, when we're going to measure it, what we see here is that, as I stated earlier, the diaphragm drops. And all we're doing is looking at from the first initial drop to 100 milliseconds later. And what is the pressure gradient established or created from that first 100 milliseconds? And you can see here, you get a drop. Now, the thing about the P100 is that the overall strength of the diaphragm, it doesn't matter. So this pressure, this nadir pressure here, this is the lowest pressure that's achieved. That has nothing to do with occlusion pressure. Occlusion pressure, again, I know I keep saying this, but I'm reiterating because it's very important to recognize, is this first 100 milliseconds of this maneuver, this inspiratory phase. This is important because what we know about the first 100 milliseconds is that even though the diaphragm is dropping and is starting to create a pressure gradient, this negative pressure that's going to allow airflow to come in, within the first 100 milliseconds, there actually is no flow or any volume displacement happening. And so this is truly the diaphragm's initial response to that neural drive without any effects of gas or anything actually moving at this point, okay? Now, what we see here is that if we're measuring the first 100 milliseconds, then if this becomes steeper, then our P100 is going to become more negative. If it becomes less steep, then our P100 becomes not as negative. And when I say that, when I talk about negative terms, I don't like to use increase or decrease because we know a negative 10 is actually less than a negative 1, but it doesn't make sense because we think of it as an increase in neural drive, and an increase in your P100 doesn't always work out like that. So I'm going to be using the words more negative on this. And so essentially, if a patient's sucking in really hard, then you're going to have a much more negative airway occlusion pressure. To measure this, you just have to occlude that first 100 milliseconds, just like we do with a maximum inspiratory pressure or a negative inspiratory force. Just like we do those where we occlude the airway and see what type of pressure is generated with maximum inspiratory effort. Now we're doing it with just during the first 100 milliseconds. And whatever that initial diaphragmatic response shows is what your P100 is, okay? Now, how does this relate to dyspnea and neural drive to breathe? Well, we know that normal values, this is for you and me right now, this is for our normal, healthy, spontaneously breathing patient. What we know is that a normal neural drive will generate a pressure of P100 of about negative 1.5. The range is actually negative 0.5 to negative 1.5. That's a normal neural drive just resting. We don't even know it's happening because we don't think about it. Nobody thinks about breathing until we can't. And so we see that. Now, we know that with a decrease in our neural drive, this happens every night when we go to sleep. We get a natural decrease in our neural drive to breathe. Somebody who maybe experiences a narcotic overdose, perhaps they are probably going to experience a reduction in their neural drive to breathe. And what you see is that the diaphragm, and within that first 100 milliseconds, creates a smaller pressure gradient. So you can see here where it's only negative 0.2 versus normal up here where we're looking around negative 1.5. If the diaphragm doesn't move at all, then your P100 is going to be 0. So that's, I think, a key point to recognize there. Anytime the patient is breathing, there is going to be a pressure generated. The smaller it gets, then the smaller the negative number gets in terms of negative 0.2. Now, it's much more interesting to talk about the increase side, because when we go back to that dyspnea conversation where all of this started, we can think back to, okay, all of those things, hypoxemia, hypercarbia, fever, exercise, anxiety, fear, pain, all of those things are going to cause an increase in our neural drive, which we can follow up and come over here and see that the negative pressure generated from that first 100 milliseconds is much greater. Negative 10 is just an example up here. It's not a value, or that's the marker. It's just for reference. Okay. So this is normal. Remember this right here, negative 1.5. That's for a normal spontaneously breathing person. But when we get into the ICU, what we see is that we're rarely taking care of normal healthy lungs and normal healthy spontaneously breathing patients. A lot of times they end up on mechanical ventilation. And we also need to recognize that these normal values vary just a little bit in regards to mechanical ventilation. This has to do with imposed work of breathing just due to the increased airway resistance from the artificial airway. Also, illness and sickness is going to increase the drive. And so it's completely out of the realm to recognize, like, okay, we're going to have a little bit different normal range. Normal neural drive If you're going to go one number, it's around negative 3.5. Now, different articles and different research have slightly different ranges. I've seen stuff anywhere from -2 to -4, negative 1.5 to -4. So -4 is not a terrible number. But the point is recognizing that as it starts passing by that -4 and -5, then you are starting to get into the realm of a patient who is not neurally satisfied for whatever reason. Again, decrease in neural drive. Again, also in ICU, this is going to be very common, especially on your patients who are sedated. It makes sense that they're going to present with a reduction in their neural drive because they are sedated. And if they're sedated properly, then that's probably where they should be. Now, this can also be an indication of over-sedation. So when you look at this and you have a patient on mechanical ventilator and you're trying to wean them off of mechanical ventilation and they keep failing because they're apneic every 20 seconds and they only have a negative P100 or they have a P100 of negative 0.2, well, guess what? That's your indication. It's like, why does this patient, we know, why are they going apneic? Well, let's look at their P100. Their P100 is negative 0.2. They're apneic because they don't have the presence of that neural drive that is stimulating that diaphragm to generate that normal range for needed to generate a breath or generate an inspiratory phase. Okay, so you take that patient who's extremely alkalotic. We've probably all seen this patient. They're 7.52, 7.55. We're trying to get them extubated, and we can't. Well, why not? Because that 7.55 is reducing that patient's neural drive to breathe. So you're not going to see good, effective, spontaneous ventilation in that patient because of the reduction in the neural drive. Now, again, over here on the increase side, as we have an increase in the neural drive, we will see that the P100 will become, again, more negative. Now, this is where I think it's extremely important, not that the decrease is not important, but recognizing increases in neural drive, I think carries a lot of weight. Because what we know and what the research shows is that patients with a reduced P100, meaning a more negative P100, greater than that normal range of negative 3.5 or negative 4, what this is telling us is they're not satisfied with something. And this is going to lead to an increased incidence of asynchronies. So these patients are going to become harder to ventilate. Why? Because they're not happy with they're either hurting or they're scared or they're not happy with the vent settings. So they're going to become asynchronous. Asynchrony typically leads to the need for more sedation, which leads to longer vent days, which leads to a higher risk for ventilator-associated pneumonia, ventilator-induced lung injuries, overall pulmonary complications, longer ICU stays, longer overall hospital days, and all of that equals higher mortality. When we have a tool here that can tell us and can show us that, hey, we have an increased neural drive to breathe, let's try to figure out how we can fix that. And it seems like the answer might be, well, we just give more sedation. But that's not always the answer. We know that we can see asynchronies show up and we can create these patients who have an increased neural drive to breathe because they're not satisfied with vent settings. For example, you take a patient who is flow hungry. We've probably all seen this before. That patient is not going to be satisfied because they're trying to get a breath quicker than what the ventilator is delivering it. Volume hunger. They want a slightly larger tidal volume than what the vent is delivering. And where does that manifest? It manifests from the neural drive to breathe going, I'm not satisfied. I'm distressed. I'm short of breath. And if you can imagine being short of breath, we stop whatever we're doing. We may hunch over. We breathe faster. We take larger volumes. And when our shortness of breath is satisfied. But during mechanical ventilation, when the vent is operating within parameters and the patient is short of breath and trying to catch their breath and they can't, this seems like an area that we may want to be able to jump into and say, hey, so let's figure out if we need to do something different for these patients, okay? So keep that in mind. Your number for mechanically ventilated patients is around negative 3.5 to negative 4. If it's negative 2, you're happy with that. You're good. Perfect, okay? If it's less than negative 0.5, then we know we have a reduced problem and we need to assess the situation. I'll tell you a quick story here real quick. We had a hands-on patient. This patient, SBT looked perfect. The minute volume was low, was coming in at about 4.1. But their MIP was negative 58. Vital capacity was almost 2 liters. This was a young patient, and everything looked golden. And I expressed to the care team that I was worried about her minute ventilation, and even went on to say she has a reduced P100. It's only coming at, like, I think it was actually negative 0.2 on the money. And I said, I'm a little concerned about this because I'm not sure why she doesn't have a more of a normal, neural drive to breathe for, let's just say she was 20 years old. It seems like we would have more of a normal drive. Well, come to find out, the care team decided, like, she'll be okay. We'll take this support away from her. She'll breathe more often. She'll be fine. But we extubated her. She was fine for about the first hour. And then an hour and a half later, 2 hours later, she became lethargic, unarousable, and took a blood gas. And guess what? Her CO2 was extremely high. And she ended up going back on the ventilator. Well, come to find out, there was a congenital process going on here that was that she had been diagnosed with a central hypoventilation syndrome from a child. So this all makes sense now. Why do we have this decreased P100? It's not something we just gloss over and go, oh, well, that didn't play a role. No, we had an indication to the potential for this happening within that P100 prior to extubating. And so, I think it's very interesting to see how we can use these to better take care of our patient and recognize them as one more tool that we have in our bag. Okay, now let's talk about the occlusion pressure and its value during the weaning process. Okay, we probably all know that there's not any one for sure, this is the weaning parameter that always leads to success. We know that. What we know is that weaning success is predicated based off of a multitude of parameters and markers. And it almost seems like the more we have, the better we get at really fine tuning and being able to identify potential problems down the road. Now, if we look at this, okay, we're just going to start here with the MIP, because that's first of all, one of the common misunderstandings about the occlusion pressure is that it's oftentimes confused with the maximum inspiratory pressure. So that's one reason why I put that up here. The other reason is MIP is obviously a very common weaning parameter that we typically assess. So let's look at patient A and patient B. When we look at their MIPs, both of these have MIPs of negative 32. Now, if we were to stop right there and say, okay, which of these are you going to extubate? If all other parameters were considered, except for the P100, you would say, well, they both have an equal opportunity for extubation success because their MIPs are exactly the same. They both have demonstrated, adequate diaphragmatic strength. What happens when we evaluate the P100 is we see where patient A is falling within a normal range, negative 2.7. When we look at patient B, we see they have a more negative P100. They have a reduced P100 coming in at negative 7.7. This is interesting because right now, even though they both have equally strong diaphragms from a diaphragmatic strength being able to generate negative 32 centimeters of water pressure, patient B is currently neurally distressed where patient A is not. Now, the research takes this down one step further and gives us another parameter to look at. I'm going to pull out my calculator here because what they talk about is this new ratio. And I know we were all thinking like, she's another ratio. Yeah, another ratio is the P100 to the MIP. This is where you just compare now the MIP to the maximum inspiratory pressure. So if we do that for patient A here, we'll do 2.7 divided by 32. And what we see is we have about 8%. So the P100 is accommodating for about 8% of the total diaphragmatic strength. Well, where we look at patient B over here, we see 7.7 divided by 32. And this patient's occlusion pressure is accommodating for 24% of their total diaphragmatic strength. Now, the marker here is around 14 to 15%. Anybody with a P100 to a MIP ratio less than 15%, assuming that the P100 is not gone like 0 or negative 0.1, but less than 15% showed to be supportive of greater success post-extubation, where greater than 15% showed to have a higher risk for post-extubation failure. Which I think is interesting because we got all these numbers, and you start putting them together and you start seeing how this makes up and how this plays together in our realm. Now, I told you the story about the young patient we were taking care of with the P100 of negative 0.2. Everything else looked good. You could arouse the person and everything was good, but her resting P100 was not well. So you want to consider that. You don't always just looking for, oh, if it's increased or if it's more negative, then that's bad. We need to consider maybe not extubating this patient. It can also not be good on the other side of things as well when you start getting less than 0.5, less than negative 0.5, which that kind of brings up another point. I just said it as a positive number. I just said 0.5. And that's kind of an interesting topic that you may want to be ready for when you go out and hopefully start talking about these things with colleagues or with physicians or your care team is that it's implied that this is a negative number. So you will see some people where they document this as so like this says negative 2.7. You would see somebody document this as just 2.7 because it's when you're talking about occlusion pressure or P100, it's referred to imply that it's already a negative number. And so little discrepancy there. I always use negatives because I think that's what it reflects, and I think that's the most accurate, but you will see it done both ways, okay? So recognize this and kind of keep this in mind when you start assessing your patients, your MIPS, and you're thinking about it prior to extubation. Ask yourself, what is my P100 to MIP ratio? Because the research out there supports that it has validity in the realm. Okay. So how do we assess? That's the question. Okay, so how do we assess the P100? And I apologize for the blurriness of this video. It's obviously off of an 840, so the graphics weren't good to start with. And then trying to get a picture of it, it's not even worse. But if you go back to the 1975s, can you imagine the complication in trying to measure a pressure over 100 milliseconds and the graphing paper that was used and the blocks marked out and all the measuring? Had to be extremely difficult, which in my opinion is probably why it wasn't around for so long and hasn't evolved into probably a more available tool based in a lot of knowledge and even in the educational process. I think back to my schooling, and we weren't exposed to this. And so probably had a lot to do with difficulty, but we don't have that argument anymore. We can't say, oh, we're not going to do that because it's too hard. See, now we have microprocessors built into our phenomenally advanced ventilators. And I haven't seen a ventilator out there today, the modern ventilator, that does not allow you to assess your patient's P100. And so what we do here is you can see where if you're working with the 840, there's this tab down here at the bottom that says RM, and that RM stands for respiratory mechanics. And when you go into that tab, there'll be 3 different options for you. You can do the MIP, you can do the vital capacity, or it has stated there the P.1. All you have to do is press the start button. You don't have to hold it. Now on another one you may have to, but most likely you just have to start it because remember, the microprocessor is going to be timed for 100 milliseconds. So you hit the start button and this maneuver is performed. Here's what's cool about this. The patient has no idea this is happening because remember, we started by talking about how the P100 occlusion pressure happens before any volume displacement happens. So it's not like this imposes some type of work on your patient where they go, I'm trying to get a breath, but I can't because this ventilator is occluding my airway. It happens so fast that there's no even recognition that this is going on. And so that's a key element. And that is why some ventilators, I want to say it's the servo, but don't quote me on that, actually assesses the P100 on every breath automatically. So you can see where this has no interference with the patient. Now, when you do this, you will get a negative number such as this. So this one here is negative 0.8. That's a good P100. You can see down here, another time they did it was a negative 1.5. And then another time they did it was a negative 0.8. Well, how often are we doing this? Well, I don't think there's any harm to evaluating as often as you want to. What I want to be sure to point out here is there's 3 of them here. And this one happened at 3:17 a.m. This one at 3:18 a.m. and this one at 3:25. So what we see here is that, and what these recommended based off of the research is that whenever you do assess your P100, you want to get an average of 3 relatively together measurements. So this is not a one-time push and go to the next one. You're going to assess it 3 times and then record the average of all of these. Now, if we were to average these, we would come out where 0.8 and 2.3 and 3.1 divided by 3 is about 1. So this person's P100 is averaging at a negative 1 centimeter of water pressure. And that's a good P100. We know that. Now, another key element when you are assessing the P100 is other than just pressing the button, what do I need to tell my patient? And the answer to that is nothing. You see, you don't want to disrupt the resting state of your patient or the distress state of your patient. What we're looking for is, what is my patient's neural drive to breathe right now? What is it? And you don't want to do anything to alter that. So there's no, hey, I'm going to do a test real quick, just breathe normal, because you just altered the breathing pattern. You just go in, perform the maneuver, no coaching. I recently heard a sales rep talk about the P100 and talked about how when you do this, you want to encourage the patient to suck in as hard as possible. That's a MIP maneuver. The P100 is a not coached technique or assessment. So you simply just go in and press a button and take your average of your 3. Any coaching will alter this value. So remember that. It's completely subconscious, no coaching, do it 3 times, take the average. That's how we're going to assess. That's how we're going to assess this patient. Okay. Now, let's look at it in regards to in mechanical ventilation. Okay. So within the mechanical ventilation process, not weaning so much, but just how can we use this for our standard patients just that are in the throes of mechanical ventilation process? Well, again, coming from the 840, I promise you the next images are much clearer. But let's just start over here for just a second. If we look at this screen of the 840, we can pull a lot of data from it, okay? We can see here that we're in volume control. We're set on a tidal volume of 520 with a respiratory rate of 27 and a flow of 70. Okay, so what this tells us is that we are currently desiring to basically provide full mechanical support for this patient. We're not in pressure support right now. So we're not in a spontaneous mode, and we're on a pretty aggressive setting. So ideally, you would think that your patient's P100 should be relatively small, right? You should think, okay, well, it's not going to be, they shouldn't be distressed right now, because we should be providing with these settings should be pretty good in meeting that patient's needs. When we look up here, we see that our total rate is 32. So, okay, we're set on 27, but we're total is 32. So we do have some patient effort happening here in the assist control mode. And when you think about this, you say, okay, is there anything up here on the waveform that might point me in the direction of my patient is not satisfied with these settings? And at first glance, you may not see anything. At first glance, it may look like, okay, yeah, it looks good. Flow pattern looks good. Well, that's because you're in AC and it's set. It's not going to vary. You look at your pressure waveforms and we see a breath here and a breath here and a breath here. But we also see breaths here, here, and here. Now, interesting thing about this is that these breaths here in the middle look vastly different than the prior breath. And this is where the distress is coming from. When the patient initiates a breath, you see that they're not happy with the way that breath is being delivered. When you look at these good-looking waveforms, you don't see a negative drop prior to the breath happening. And so these were time-triggered breaths. But when the patient asked for one and the brain, the neural drive said, hey, take a breath, I want a breath, They weren't satisfied. You can see that that pressure waveform looks vastly different than the prior one. That's our clue. Is this patient neurally satisfied? Despite being on very high settings, PEEP of 10, 55%, I mean, it looks sick, but being on what we would call full vent support settings, are we satisfying this patient? Now, the P100 measurements are over here. I'm going to erase them. I have them blacked out right now. But what I'd like to see from everybody right here, maybe not on this one, but on the next one, is I'd like to see your comments coming up to tell me if you think the P100 is going to be more negative or less negative or normal. Okay, so feel free to throw in the chats there on what you think is going to be happening with these patients. Okay, because we're going to be looking at a couple of different waveforms here for just a second. Now, again, kind of put this on, you've already talked about the asynchronies that are happening over here. So clearly this patient's going to have an increased P100. And when you look at this, what we see is we get 6.3. I'm going to rewrite these so you can see what they are. Negative 4.6 and negative 7.2. So negative 6.3, negative 4.6, and negative 7.2. 857 in 28 seconds, 857 in 36 seconds, 857 in 44 seconds. 3 consecutive P100s done about every 14 or 15 seconds apart. And if we're breathing 30 times a minute, then that's about every 6 to 7 breaths, right? So when we average these, we get an average of about negative 6.0. Okay, we add all these together, divide them by 3, we'll come out with about negative 6. That is a reduced P100, lower, more negative P100, and it indicates that this patient is not satisfied with these settings. Now, here's the interesting thing about this. At least I find it interesting. I hope you find it interesting too. The backstory to this patient is that this patient has been battling severe ARDS. And we have just suspended or stopped the use of a paralyzing agent. And so the patient is now able to generate these breaths where just slightly before, when the paralyzing agents were active and still in full effect, we didn't see this. The total respiratory rate was 27 because the diaphragm could not initiate a breath. Now that the patient is awake and alert and is attempting to initiate breaths, we're seeing it happen. And we're getting a P100 measurement because we have an active diaphragm again. But here's where this gets really wild to me. If the only thing that changed here was the suspension or the discontinuing of the paralyzing agent, okay, and nothing else changed, then what was this patient experiencing during the full effects of the paralyzing agent? Because remember, paralyzing agents only paralyze muscles. They don't drop sensations. They don't reduce sensations at the brain level. So the neural drive to breathe, if this is what we get after discontinuing of paralyzing agents, that signal was still being sent the entire time. The diaphragm just couldn't respond. And so I guess my question is what is that? How do we think about that? How can we use that information? How can we take that and go, wow, like that doesn't seem, I'm wearing my humanities shirt. And so that doesn't seem very humane to paralyze somebody, but they still have this neural sensation that they're trying to breathe, but the diaphragm can't because it's paralyzed. So perhaps we could use the P100 for this patient to identify the appropriate level of sedation to reduce to the maximum level the neural drive to breathe prior to paralyzing the patient. And once we get there, then we can sustain that sedation where it needs to be to basically eliminating the neural drive. And now we can apply paralyzing agents without creating this neural distress that we'll never know about until we discontinue the paralyzing agents. Okay, I told you the images were going to get a little better. Here we go. We're looking at a patient here who, let's just break down this knowledge, and I'm going to share it with you. And again, this time I want your words in the comments. Is it going to be more negative, or is there going to be less negative, or is it going to be normal? We are in spontaneous mode of mechanical ventilation. We see we have a PEEP here of 5, a pressure support of 10, and we're on 35% oxygen. That's basically minimal settings. We could go slower on the pressure support during an SVT, but for the most part, we would all agree that those are minimal settings for the most part. When we assess what is happening with our patient, we see that we have a respiratory rate of 20 breaths per minute. So this looks good, right? Nothing concerning there. And when we look up here at our tidal volume, we see that we have an exhale tidal volume of 527 and an expired minute volume of 10.4 liters. So we have about an average tidal volume of about 500. Now, if we are looking at extubating this patient, then one of the things we probably would do is obviously assess rate, assess tidal volume, and then we would put those together and we would assess the RSBI. So we're going to say, okay, well, what is this person's RSBI? Rapid Shallow Breathing Index. Well, if you divide 20 by 0.5, you will get 40. So the RSBI is 40. Everything looks good. What do we think? Normal P100, more negative P100, or reduced P100? So Joe says normal. Let's see, there's several more of us here. Someone else throw up a thought right there. Negative, so more negative, okay. So we've got normal and more negative. Now, normal, so we got two normals to one more negative. It's obvious it's not going to probably be reduced. We got somebody breathing 20 times a minute, tidal volume of 500. It's probably not going to be like 0.2. If anything, it's going to be normal around negative 3.5, or it's going to be more negative. My point in all of this is to show you that when we look at the P100 being measured, that's the measurement right there. And that measurement is negative 7.4. So the P100 equals negative 7.4. Why is this interesting? This is, to me, it's interesting because you take a bunch of data that looks, for the most part, pretty good. I don't have too much concerns over any of this basic data that I can see on the screen until I dive just a little deeper and assess the patient's P100. And what I find here is that while everything may look good, this patient is still experiencing some level of neural distress. They're short of breath. They're dyspneic. And that's what the P100 is telling you. Now, this may be due to pain, maybe due to fear. We don't know. All it tells us is that is present and why. That's what we have to figure out. Now, we do know that if this is related to not being happy with the ventilator settings, research shows that if you ever see this and you have a patient in pressure support ventilation with an increased or a more negative P100, an abnormally low P100, one of the ways we can treat this is, instead of evaluating this and interpreting this and saying, oh, the patient must want more pressure support, which is what the research found to be the common answer is. Well, we don't need to give this person more pressure support. Their tidal volumes are good. They got a good effective tidal volume. They got a good RSBI. They don't need a bigger tidal volume. It doesn't appear that way anyways. So what they found was that in this case, what we see is that adjusting the rise time for the pressure support led to better satisfaction from the neural level. So they don't need more support. They just need that support quicker. Get it up to that pressure support of 10 at a quicker rate. And you'll see where they become more neurally satisfied. And yes, Kim and Steve, I agree. They want the tube out. Okay, let's look at one more scenario here. Ignore the hand over here. Don't pay attention to that. So what we note here is, again, you're going to see the P100 right here. But to start with, we see where we have, again, we're in spontaneous. Where does it say spontaneous? Spontaneous, right here. Spontaneous. We're in CPAP. We got pressure support on. And we see we have a rate of 34. And we have an exhale tidal volume of 354. Now, that's just one tidal volume. Our vent is telling us down here that our average overtime RSBI is about 70. Okay. Now, we're on a PEEP of 8. Doesn't tell us what our pressure support is. But we know we're on a PEEP of 8, and we know if our PIP is 21, then we're probably on a pressure support of around 12 or 13. Okay, I'm going to lean towards 12 because nobody sets odd pressure support numbers. But anyways, 12 or 13 is where we're at and what the patient is getting. You would agree that this patient is on higher settings than the patient we just looked at, and all of their parameters look worse than the patient we just assessed. Okay. So what do you think this P100 is going to reveal? More negative, normal, more negative or normal? We know we're breathing 34 times, so it's not going to be reduced. It's not going to be 0.2. So what do we think? Joe's going normal. We're playing the odds here, right, Joe? He's tricking us here, right? He's playing games with us, making us think the patient looks bad when they're really not. Well, for time's sake, let's just show you what the P100s are here. You can see here, this is negative 1.2, negative 0.8, and this is the two that were done right here at 10:51, and this is 10:52, and we look up here at the time, and it's 10:53. So we're about to do another one right now. That's what this person's doing. They're hitting the start button on their P100. But even at 05 o'clock, they were negative 1.4. Now, how, for me, mind-blowing is this. If I walk into this room and I see this patient breathing like this 34 times a minute, tidal volume's 350, higher settings, worse RSBI, I'm thinking, wait a second, this person is going to be more distressed than the person we looked at previously. RSBI of 40, tidal volume of 500, rate of 20. This doesn't add up, right? It doesn't. But what this tells us, whether you want to argue with it or not, and that's kind of the point here, is when you ask that patient, how do they feel? Shortness of breath. Are you short of breath? And they tell you no. Even if they look short of breath, you can't tell them, yes, you are short of breath. That's not the way it works. Dyspnea is a subjective response. Neural drive, how a patient feels from breathing, is a pure subjective response from the patient. So we see here that this patient, despite numbers and everything looking worse, actually is more satisfied than the previous patient that looked better. So this is all very, very interesting to me. I think what it comes down to is, in summary, is kind of going back to where we started, is recognizing what the occlusion pressure is, knowing that it is the negative pressure generated within the first 100 milliseconds of an inspiratory effort, and that it tells us a reflection of that impulse sent from the neural drive to breathe. Most of the things that we evaluate and monitor give us information about the alveoli, about the airways, about the overall strength of the diaphragm. Leave this lecture today understanding that occlusion pressure has nothing to do with diaphragmatic strength, has everything to do with the neural drive to breathe. It starts here, and that's what it's a reflection of. It's valuable during the weaning process, when it gives you just more information where you can do the P100 to the MIP ratio. And even during mechanical ventilation to identify asynchronies, flow hunger, volume hunger, and overall just allow you to communicate with your patient, to allow that patient to tell you from a measurement on a ventilator that I'm not neurally satisfied right now with the current position of where we are. Okay. I had a close friend of mine who says it best, says when we commit ourselves as a healthcare team to telling a patient that we can breathe better for you with this mechanical ventilator than what you can breathe for yourself right now, then we dang well ought to be able to do it. And the P100 is the tool that gives us the assessment of if we are or if we aren't. So that's where I leave it. I have references here. I know you can't read those, but if you would like a copy of them, you can reach out to me through various social media platforms. Find me on Instagram at Respiratory Coach, YouTube at Respiratory Coach, Twitter, Coach RRT. Always can send me an email to respiratorycoach@gmail.com. And if this is your first time here, or maybe your second time and you didn't do it the last time, I have a texting platform where I just send out occasional inspirational, educational, motivational thoughts to help bring and kind of just connect greater with the RT community and hopefully drive us towards the future in improving and learning about some of these tools that we either didn't learn or have never learned or forgotten about. And so if you have any questions, I'd love to answer them. I'm very passionate about this topic. If you couldn't tell, we could easily be here till 11:50 if it was up to me. But other than that, I'm going to open it up to you for questions. Yeah, that's a good question, Keith. Are you asking me? I don't. So the funny thing is the answer is I don't know if anybody in the group today is doing. I want to hear from you. If you're asking me if anyone is using this, not to my knowledge, I can't tell you. Oh, they're using this over here in facility X. I think it's starting to gain traction. But I think it's primarily being looked at in the weaning aspect of things rather than the overall part of our I mean, this is something that could easily be done with every patient assessment every time you walk into your room to do a vent check. No, let's turn it into a patient ventilator assessment and actually ask ourselves, how satisfied is our patient right now? What can we do to help them better? So, that's kind of where I'm not seeing it used very many places. It's funny. I had an interesting conversation with a nurse practitioner yesterday, and she talked about how passionate she is about recognizing the neural drive to breathe for her patients. And so I brought up the occlusion pressure, and she had never heard about it. And so it's interesting to me that we know this neural drive exists, but we don't talk about occlusion pressure enough. And so absolutely, I think it's a valuable tool, and I think it'll become more valuable and prevalent as we just keep moving and start talking about it and start documenting it and start assessing it with our peers and in our electronic records. Yeah, I think, Keith, what you're doing is about what is happening in most places. If anybody's doing it at all. I just graduated last year, and this was not presented in class or during my clinicals. Nope. Not for me either. And as a matter of fact, I do not teach the mechanical ventilation class within my program that I work with, but this is one of the big key areas of focus that I try to start exposing my students to during the clinical process. So it's definitely something that is definitely flying under the radar right now and so undervalued, in my opinion. Well, how it can be used in weaning is what we talked about. When you would not think about extubating a patient who is displaying on the vent with PEEP and pressure support and all of that stuff if they're demonstrating a more negative P100, if they're demonstrating neural distress. And I'm not talking about based off of just agitation, like let's get this thing out. I'm talking about they're still not right. They're still sick. Then you probably make sense that you don't want to extubate that patient, especially if you have somebody with a negative, let's say they had a P100 of -10. I think the highest or the most negative I've ever seen is like -14. All I had to do was increase the flow and rate came down and P100 dropped to -7. Interesting. Made a massive improvement just by changing flow. But let's say somebody has a P100 of -10. And they have a MIP of -20, just to make the numbers easy. Well, that's that P100 to MIP ratio of 50%, which means that 50% of their total overall diaphragmatic strength is being used within the first 100 milliseconds based off of a neural impulse. And so I think it just can speak to neural distress before you think neural distress is going to go up or down post-extubation, unless it's somebody just really ready to get anxious to get that tube out. Probably going to be higher, right? And so I think that's how we can use it in weaning. Any other questions? Any other thoughts? If not, I thank all of y'all for being here. I enjoyed this. Appreciate the comments and the questions. And I hope everybody has, a good, next couple of weeks as we enter into or stay into the throes of the holiday season. And just best wishes for everybody. And thanks for being here.